So we're now going to move on to hearings about some of the winners of our Patient Safety Challenge funding. So the Patient Safety Translational Research Centre put out a call just over a year ago to teams of healthcare professionals and patients from Imperial NHS Trust to come forward with some ideas for interventions that could be developed and evaluated to look at patient safety. We had more than 80 applicants, and these were shortlisted and subject to a Dragon's Den style interview process. We had 10 winners who were awarded funding. So we're going to be hearing from 3 of those this afternoon, and Dominic King, who's one of our clinical lecturers in surgery, will be introducing that, and Dominic has overseen many of these. So over to you.
Thanks, Bryony. In the Huxley building and lots of these buildings around South Kensington, there's people working on new molecules, engineering new solutions that can really have a transformative impact on healthcare. But we're talking about in a decade's time, if we're lucky, sometimes in a generation's time. The focus of a lot of our work here is actually in the here and now and trying to solve the problems that clinicians and patients are facing today or tomorrow in clinic. And this is the kind of real interest of the technology and design theme of CPSSQ, which didn't exist in the first iteration. Like Alex's work, it's a new theme, and I think a very exciting theme, and the Patient Safety Challenge has been a big part of that. So we are one of the 6 program themes, and our aim within this theme has been to develop and test new products and services that can impact on patient safety and improving quality of care. Now, when we wrote the proposal, I remember writing the proposal, I think it was 3 Christmases ago, I think Karen will correct me, but we said, we envisage creating a centre to do all this work through. I think we called it the Healthcare Design Unit. It was HDU. And that subsequently changed when they got someone good with names into the Helix Centre. We applied for very substantial funding, which we were lucky to receive, and we have created something which many of you have seen, called the Helix Centre. As Prof mentioned, it's a joint collaboration between the Royal College of Art and Imperial, and Imperial College Healthcare. We have grown from a couple of us to, this is just our designers, there's PhD students sitting in the audience, and we have a team of fantastic designers and developers. This may not come across too well, but this is our design studio right outside the entrance of St. Mary's. I think Prof has an article in The Guardian today, which he describes this building as a Chinese lantern. I'll let you decide. But it is an amazing resource for our team. So it's been on site, I think, for about 8 or 9 months. It was the focus of the Royal College of Art Masters in Architecture Prize. It is beautiful. It is a beautiful place to work for those of us lucky enough to call it home. And this is where our designers sit. Patients and staff will knock on the door. They'll come in, ask us what we do, what problems, tell us about what problems they face, and we have this fantastic design team that can start thinking about solutions. So our emphasis at Helix Centre is producing cost savings to the NHS, being self-sustaining through spinning out companies and intellectual property. And really we're trying to answer these or work in these areas, how to do more with less, something we're all familiar with, and Alex has just been discussing, and really to solve the problems of frontline staff and patients. So that's our goals, and they fit very well with this patient safety challenge. So in June 2014, we challenged healthcare staff across Imperial AHSN to come up or submit applications for ideas, solutions, products, services that they felt could improve, in many cases, how they work, but in doing so could improve patient safety and quality of care. We were lucky through this patient safety centre to have approximately £300,000 to support these projects. And on top of the financial support, we were also able to offer our expertise within the centre, of which many people sit here, and the Helix Centre to support these projects. So it's not just about cold hard cash. We had an incredible response. We had 80 applications. Project leads included everyone from the most senior doctors in the trust right through to every healthcare profession. Project teams, we funded incredibly experienced researchers, some of whom sit here, but we also funded people who actually have no research expertise or experience at all. And this is when I talk about giving people expertise and support from within the centre as necessary. Ideas encompassed many healthcare apps, service improvement methodologies, education and training programs, and you'll hear about some of these as we go forward. In the nature of a frugal event, I don't think we had Sunny or an exceptional cameraman such as him at this event, so the pictures aren't particularly great, but it was a fully attended event. 11 teams presented their idea. Their panel included Yasmin, Professor Darzi, Martin Bromley, who many of you will know, representatives from the Trust, and teams had to pitch their idea within 7 minutes with opportunity to receive questions from the audience. The presentations were fantastic. So Karima, who will be presenting what she's been up to, anyone that was in the audience will remember that she made Yasmin and Professor Darzi thicken their fluids as we expect patients and staff to do. And I think we have to say that their efforts were fairly unsuccessful in keeping with what actually happens in the wards. So we'll hear more about this project. The level of quality of all their proposals was so great, we pretty much funded everyone, which was great. We did it, there's a robust governance about this. This is, money that needs to be spent on projects that can have an impact. And so we, although teams may not have been hugely experienced in research plans and planning, we did expect very detailed proposals, financial costings, and Renata has been responsible for rigorously monitoring with project updates as any of the teams will testify. And most of the teams, by and large, have been working on these solutions for approximately a year. Many projects are nearing completion, and we're really now starting to see their potential impact, not just at Imperial, but at other hospitals. I'm just going to talk over a couple of the projects before introducing you to their main events. Some of these projects are kind of cross-cutting. We had a number of projects which kind of fitted the same theme, one of which was how do we provide information and decision support to frontline staff. Now, at Imperial, there are literally hundreds of guidelines for anything from management of atrial fibrillation to how to prevent patients having DVTs. When we're meant to follow all these protocols down the line, through from start to finish, and that's actually very difficult. These protocols usually reside on the internet somewhere, very difficult to access, particularly at 3 o'clock in the morning in the emergency department. And a couple of project pictures really said, I want to provide these important guidelines to staff when they most need them. And the idea really is that these are delivered on people's smartphones. Now, this is a piece of work that we've just completed at Imperial, funded by the Patient Safety Centre and through our theme, which was a survey of all doctors and nurses at Imperial College Healthcare. And the reason I'm showing this is because every single one of us is walking around now. 99.6% of doctors, 97.6% of nurses are walking around with computers in their pockets. One of the real problems with getting information to doctors and frontline doctors and nurses has been that we have 3 computers in the ward and we're all queuing up to use it. So this is important because we should be using these devices to support and deliver information to our staff. So 2 of the projects we funded, This is Krishnamurthy, one of our upper GI surgeons, who also leads the trust on preventing surgical site infections. These are issues that have major implications across the trust. So those of us that operate, trying to find these guidelines when you're also trying to complete an operation note and send a histology form is pretty difficult. This is now, or will very soon be available on everyone's smartphones, and it's just the information in a very salient, nice format that Krishna at any point can edit. Using exactly the same template, any junior doctors here will know that when you first started in the hospital, like many people started last month, one of the first questions is, how much warfarin should I give to a patient? These are the questions that when they go wrong, kill people, and they do kill people. And these guidelines are now being provided, they already were being provided on people's smartphones, but we've transformed that into what we consider to be a much better format that importantly answers questions around governance and regular updates. If this isn't regularly updated by the clinical team responsible, it will stop working. And that's not the case with many of the guidelines apps that are currently available. One last project before I hand over. This was Paul Ziprin, another one of our surgeons. We didn't award it just to surgeons. Easier reporting of adverse events. Now, we were actually discussing in a meeting we had this morning about, we need to learn from our mistakes and to deliver effective interventions. We need to know the scale of the problem. And we know from Charles's work about the 10.8% that took a lot of time to find out. And actually, we should be picking most of this up prospectively if we're ever going to be able to act on it. So what we've set out here to do is working around morbidity and mortality meetings, which many of us take part in, is to find a prospective way of collecting all the sea of incidents and adverse events that take place. We know these events happen and we need some way of recording them. And just as a kind of anecdote, last week we had our morbidity and mortality meeting, and the day before the house officers came up to all of us and said, any events to report for the last month, because we need to put the presentation together. And most of us were just like, no, I don't think so. Now, when we presented the next day, morbidity 0, mortality, we were pretty safe at knowing who's died. But no surgeon here has 0 morbidity. So what we're trying to do here is collect this information prospectively. On a ward round, we say to one of the team, please just report this incident. And this is what the solution looks like. So very simple, report morbidity, report mortality, simple form fed into a secure database, held on a trust server, that when it comes to M&M meetings, we can easily access. So relatively simple tool, relatively cheap, and we hope that this can have a really big impact on how units actually run. Now, incident reported, thank you very much. Now, I'm going to hand over now to Jeremy, who's a quality and safety lead at Harefield, who we funded because he proposed a really ambitious plan of how simulation training could actually be applied at the blunt end of a speciality where serious events do happen. So, Jeremy, if you're kind enough to come up.
I'm going to talk to you very briefly about a project, as Dominic said, to improve cardiology teams' preparedness for emergency scenarios. And the problem that we're facing comes in 3 parts. Firstly, the number of patients having cardiology procedures has exploded in the last 20 years. For interventions, so ballooning and stenting restricted arteries has gone up by over 1,000%. And that doesn't count the diagnostics, congenital, electrophysiology, and the hybrid surgical procedures. So the number has gone up dramatically and very quickly. And with that comes the complexity. Firstly, from patients who are getting ever older and ever frailer with increasing more comorbidities, but also medical advances are keeping pace, and so we're able to operate on patients who never would have been able to previously. And the consequence of that is that the likelihood of emergencies, of complications, goes up quite dramatically. And so we've got volume, complexity, but also training. Training time, as I'm sure I don't need to tell you, is very hard to protect within healthcare. And also doctors' availability seems to be close to nil. I found. And also, emergency management, crisis management isn't something, as far as I can see, that's taught at any stage in medical training. And certainly all of the skills that I've been teaching in this project have come from my experience as an infantry officer. There's certainly nothing that anyone could contribute from their medical training. And so they were the three component parts of the problem. And what we really wanted to do was break this here, the cycle of adverse incident followed by investigation, action plan, and then some proposed change that tends to fizzle out all too quickly. And so our objectives were, firstly, to develop familiarity amongst the teams with the stress, but also prepare them for the urgency necessitated by an emergency scenario. And one of the biggest things was getting a shift from a very reactive team, looking to the lead from the experienced consultant cardiologist, to being proactive and preparing things so that when the cardiologist needed them, they're there ready for the outstretched hand. And this was the biggest shift that I think we've managed to achieve. And part of the reason for this is the think-do paradox. The human brain, no matter how many initials it has after its name or how much experience it has, simply cannot do, i.e. Fix a very intricate medical problem, relieve a tamponade or repair a dissected artery, and also coordinate the team, at least not without making a lot of mistakes. And so we wanted to relieve the pressure on the cardiologists. And to do that, we've produced a series of checklists for all of the high likelihood and high severity complications that you'll find in a cath lab. They're very simple documents with 3 columns: people to call, drugs to prepare, equipment to prepare, and any questions or prompts for the cardiologist are in a very simple yes/no question format to put the minimum demand on the cardiologist's attention. Also, we wanted to make effective communication almost muscle memory, so that it happens without thinking about it, acknowledging instructions, reading back drug doses to make sure you got them correct, and also confirming that any instructions have been carried out. And finally, to get the drills that people have to follow really familiar. So, for example, collecting emergency blood. Very few people get to do it, and you can bet that when you do, it'll be 2 o'clock in the morning, and you simply haven't got time to think about what to do or anyone to guide you. So, moving on to what we've achieved. We've run 27 training sessions in the course of the year, 11 at the Brompton, which follow the process I've just described, and 16 at Harefield, where there's already a fairly comprehensive program of training. So we were looking more at how to develop teams' ability to respond when there aren't any doctors present. We've covered all of the high likelihood and high severity complications, initially individually, but then we strung them together into combinations to further test the team's ability to react. We have a folder of these checklists which sits at the back of the cath lab waiting for its moment of glory. And I'd like to share with you 3 quick examples of when we've produced tangible results. The first was a very junior radiographer, barely out of training, who took the lead on a cardiac arrest, her first cardiac arrest, all on the back of the training that she had received. The second was a registrar who acted as the operator during a tamponade training session on the Wednesday, and on the Saturday found his first solo tamponade on call at about 2 o'clock in the morning, and said that without the training he would have been completely lost. And the third was a TAVI procedure, one of the transaortic valve insertion, one of the more complicated and more recent cardiology procedures. And I wasn't involved in either, but one of the consultant cardiologists who was heavily involved in the setup of this project. And in the first, the patient died, and whilst I'm sure there were many contributing factors, one was that it took quite a while to get the pericardial drain inserted. So we incorporated that in the training, and literally a week later, the same thing happened, and this time the drain was in within 3 minutes, and that patient survived. And there are several others, but those I think are the 3 highlights. And there are a couple of pictures of what we were doing. One thing we have spent a lot of time doing is making sure that things like the WHO checklist, or our variant of it, is always carried out in full during simulation to ensure that it becomes more habit, so it's used when we're not training. And so our future plans. The first is to try and move in the training beyond the predictable, to have the complication next time in the lift or in the corridor between the ward and the lab, or vice versa, to really test people's ability to think on their feet. Also, we're going to bring in the crashed calls, bring in our ITU, our intensive care and all the other parts of the hospital that interact with the cath labs. I'm currently planning an exercise in which a pregnant patient has a cardiac complication on the ward, and this involves collaboration with Chelsea and Westminster. And certainly as part of the planning, a number of our doctors are going on a course at Chelsea and Westminster to learn how to do an emergency cesarean section. And then we'll have to work out what equipment we need to hold, how we get hold of the Chelsea and Westminster team, and how we get them across with everything they need to the right place. So a very necessary piece of training, I think. And also we want to do more training more often, involving more of the staff until it becomes part of the routine, and to share everything we've learned, to collaborate wherever possible, and so more abstracts, more conferences, more travel. Thank you.
Thank you, Ned. And then after that, Karima, who I will, I've already introduced the project, but she will tell you the importance of thickened fluids and what she has done with the Helix team to kind of really make a difference.
Pressure there to live up to my last acting event last year. Hello, I'm Karima. I'm the clinical lead speech and language therapist at Imperial Healthcare. And I'm here today to talk to you about the Thickened Fluids project. It was actually the idea of my colleague who can't be here today, Lee, so he's acknowledged here. And it's about improving the safety of patients who require their liquids to be thickened for medical reasons. So what's the problem? Well, thickened liquids are commonly prescribed to improve swallowing safety in patients who can't control liquids in their mouth or their throat. A special powder is used, and this is used to thicken the drinks, and it prevents the drinks from being aspirated into their lungs. The thickening powder is dispensed in a tin at the patient's bedside. It's just a little tin, and it sits by the patient's bedside, and the nurses use that powder to thicken up the drinks. So what's the problem with that? Well, there are no nationally agreed guidelines, descriptors for the thicknesses of liquids. So when the nurses are doing it, they have no idea what they're aiming for except for a rough sort of name that somebody's come up with in whichever trust they've been working in before. The quality of the instructions on the tin is very poor and very difficult to follow. And there's no robust training program and no proper educational tools to enable nursing and other healthcare staff to learn how to thicken fluids. So this all leads to inconsistency in the preparation of the thickened liquids, and this in turn increases risks to vulnerable patients. And these risks include choking, aspiration pneumonia, and dehydration. So what were our objectives? Well, initially our proposal had two elements. We wanted to prepare some simple tools and resources, including an app, to enable staff to learn how to thicken liquids in an appropriate and consistent manner, and to design and implement a rolling training program for staff so that we would reduce the risks created by incorrectly thickened liquids. After our presentation last year to the Patient Safety Challenge was successful, we were offered the chance to collaborate with the Helix Centre to come up with a solution. We met with members of the Helix team, we chewed over the problem, and we considered some of the solutions. It was decided at that point that we should focus on the creation of some simple tools and resources, and these should be in a very simple and clear format, and the aim would be to communicate very effectively the guidelines for thickening the liquids. We felt that if after we'd implemented these tools, we still needed an education program or package, then we could deliver that at a later date. So what have we achieved so far? So we have managed to develop a very consistent visual language or communication style. It is very clear and simple, and we've used it across all our resources. We've created professional posters that we will put up in appropriate clinical areas. We've created pocket-sized reference cards for frontline staff to use. And we've created some stickers that we'll put on the lids of the tins of thickener that sit at the patient's bedside. And these have been created to fit exactly onto the lid of the tubs of thickener. They're also designed to be patient-specific, which I'll show you an example in a minute. And so speech and language therapy staff will use the sticker to indicate which consistency the patient needs. And also there are some guidelines to remind staff about how many scoops of powder are required to thicken to the appropriate consistency. So here are some examples of the resources that we've created. This is the poster. You can see how clear and simple the illustrations are. We've been through multiple versions of the text, as you can imagine. We've trialled many colour combinations and lots of different types of illustrations as well. And we want to do that to try and achieve the right effect. As you can imagine, you can see on the right-hand side here that it was particularly challenging to try and illustrate in a picture, in a static picture, what is in effect a fluid, a moving thing. This is a staff reference card. You can see that it's got the same colours and illustrations and text as the poster, and it's also designed to be very easy to print and to fold. So one of the design elements was how to create something that folded neatly and quickly into somebody's pocket. And this is the sticker that sits on the lid of the tub of thickener. Again, the colour and the illustration theme are continued, and we're hoping that this kind of branding will reinforce the learning message once we implement the tools. And as I mentioned, the sticker includes, you can see there, you can tick which one is appropriate for the patient, and it also gives a reminder of how many scoops will be needed. So what are the next steps? We're going to evaluate the tools that we've created so far. When I was writing this slide, I was thinking about the evaluation, and I was really delighted actually that Alex mentioned in his talk about the difficulties of evaluation. It's been one of the things we're talking about at the moment is how are we going to measure the success of this? And it's been something that we've been chewing over with the two designers, our design lead in particular. So we've decided at the moment that we're going to compare two groups. We're just going to take some people. We're going to have one group who use the instructions on the tin to thicken, and we're going to have another group that uses our resources, our poster, and we're going to see how easily they follow our instructions. Secondly, we're going to conduct a trial on the wards. So we'll collect some staff feedback at that point, and we'll compare the responses on the wards. Exactly what responses and what we're going to look at, we haven't finalised yet, but we have been, as I say, been thinking about that in quite a lot of detail. It would be quite hard to work out exactly, sort of trying to show that there's been a decrease in incidence would be quite a hard measure. And then we're hoping that this evaluation will enable us to make any changes we need and to plan how we'll implement these resources across our hospitals. We're also in the process of developing a patient and carer booklet. So we have the frontline staff who often, particularly for very vulnerable patients with communication difficulties or cognitive difficulties or physical disabilities, they're dependent on staff to thicken their fluids for them. If the staff aren't doing it, then a loved one or a carer is doing it for them. And then, of course, those people will go home, and they may still require thickened fluids in the community. So we will coach them in how to, either the patient themselves or their relatives will coach them in how to thicken. So that's what the booklet will be aimed at. It will be addressing frequently asked questions, and it also illustrates the different thicknesses of liquids. And we're going to keep it in the same format. We'll keep the same visual language as we've used in our other resources. We've also begun work on an app, and that will explain, again, very simply how to thicken liquids, and it includes some animations of the thicknesses. So that's the benefit of having the app, is that you can actually have some moving pictures of what the fluids look like. The different thicknesses have different viscosity, and they move in a slightly different way. So it will be easier to illustrate that in the app. And that's an example of what where we've got to so far on the app. Thank you very much.
So just to conclude, thanks so much, guys. That was absolutely fantastic. So we're expecting most of these projects to be completed at some point over the next 6 months to 12 months, with a bit of leniency for some people. So we'll be continuing to support from the centre at all the projects. And Karima's mentioned about evaluation. There's people in this room who are experts at this kind of thing. So we're hoping that we can draw on expertise across the centre. I think the interest in the challenge, the 80 applications and the quality of the 11 applications that presented, or the pictures that were presented, kind of demonstrate how much enthusiasm and how much knowledge is out there on the wards, and we as a centre need to be capitalising on that. And if we solved even these 3 or 4 problems that we've discussed here in the next couple of years, we'd go a long way to proving value of the grant that was given to us. You know, with Croft's enthusiasm for this, these kind of Dragon's Den types events we found to be incredibly fruitful, and would encourage anyone out there with similar ideas to really go for it and draw on the knowledge and expertise of frontline clinicians and patients. So thanks for that. Not sure if we have any time for questions.
You didn't really allow time in the programme for questions. I'm half wishing we had now, because I'm sure there must be lots of questions and comments. That was absolutely fascinating. So a big thank you to all of you, to Dominic, to Jeremy and to Karima.